All right. Good evening, everyone. Thank you so much for joining us tonight to learn a little bit more about the Americans with Disabilities Act and healthcare. Our presenter tonight is Lauren Howard, who is the North Carolina Office on Disability and Health Director with the Division of Child and Family Wellbeing and a former colleague and fantastic partner of the Exceptional Children's Assistance Center. We are super pleased to have her join us tonight and sharing this wonderful, important information with us and all of you. If you haven't already, if you'd like to introduce yourself in the chat, let us know where you're joining us from. We'd like to see where everybody's joining us from and are just so pleased to have all of you join us tonight. I'd like to share that we encourage questions, and we know that you have had an opportunity to submit some questions ahead of time, and Lauren is going to do her best to address those. And we know that other questions might come up during the presentation. If you could please use the Q&A to put your questions in as you think of them instead of the chat, because the chat tends to get bogged down with a bunch of other comments, and we want to make sure that we're able to answer and address everybody's comments and questions. So if you could just please put all questions in the Q&A, we will have time at the end to get all of those answered. And I also want to share that I will send a follow-up email on Monday with a link to the recording of this webinar, a PDF of the slides, and some additional resources that Lauren would like to share with all of you. And we will definitely get that to you by Monday. So with that, I would like to welcome all of you one more time, and I'm going to go ahead and turn it over to our presenter, Lauren Howard. Lauren?
Thank you so much, Christy, and I appreciate you all taking time to be with us this evening and taking time away from your busy schedule and dinner and everything else that's going on in life. So I hope that this is beneficial for you and this information is valuable. And so before we get started, I just wanted to share a little bit more about myself and why this topic is so important to me. I have used a wheelchair since I was 10 years old and have had extensive interactions with our healthcare system, both before the passage of the ADA and after the Americans with Disabilities Act, or ADA. And as I have navigated this system over the years, I have learned how to advocate for myself and the importance of having this information and having resources available to me that I can not only share with providers, but truly have an understanding of what my rights are and what I have the right to ask for in healthcare settings. And so this topic is definitely very personal to me as well as part of my job. And so I think that makes it makes the ability to share this with you even more impactful for me personally. So let's jump into what we're going to cover this evening. And so first, I really want to provide an overview of several disability non-discrimination laws that apply in healthcare settings to set the stage for our discussion on the Americans with Disabilities Act. So we'll go over those very, very briefly and really spend most of our time discussing the Americans with Disabilities Act as it applies to healthcare. And we'll talk about reasonable modifications. We're going to talk a little bit about effective communication and accessible facilities and accessible medical equipment. And so with that conversation, finally, we're going to review some of the strategies that I have learned myself, I've learned from others when advocating in healthcare settings. And so it's a lot that we're going to try and get through in a relatively short period of time tonight. It's unfortunately going to be a higher level discussion. We won't be able to get too much into the nuts and bolts of some of this, but I'm hoping that it will provide you with enough information to begin or to continue your process of advocating either for yourself or for your children or for those that you care for or work with in your roles. And like Christy said, please As you think of questions, please include those in the Q&A, and we definitely will have some time at the end to get to some of these questions. So what I wanted to touch on before we talk specifically about federal laws and the Americans with Disabilities Act is to share a little bit of information from a survey that was done in 2019 of 714 physicians. And this includes both primary care physicians and specialists from across the country that, and many of them are smaller community-based practices. And so um, this study found some of the really relevant things to what we're going to be talking about tonight has to do with what physicians know about the Americans with Disabilities Act. And the study found that a third, 1 in 3 physicians reported knowing little or nothing about their responsibilities under the Americans with Disabilities Act. And then 1 in 5 reported, only 1 in 5 reported using accessible weight scales, and less than half of those physicians were confident in their ability to provide equal care for patients with a disability. And so I read numerous articles about this particular study and the results of this study. And all of the articles really emphasize these amazing, surprising results. Aren't you shocked? Aren't you surprised that physicians weren't aware of the Americans with Disabilities Act or didn't feel like they could provide equal care? And what was interesting is that I would read those articles and think to myself, you know what, I'm really not that surprised at these results. This is for those of us who interact with physicians on a regular basis, these results may not be surprising at all to you. But I bring this up and I bring this study to your attention because I think the perception of physicians is really important for us to keep in mind as we're talking tonight about the Americans with Disabilities Act. Because in many cases, as we see in the study, you are going to be the ones who are the expert on the Americans with Disabilities Act and access. It's not the physician who's necessarily going to know what the law says or what they need to be able to provide in that situation. And so let's jump into an overview of several of the federal laws that address disability discrimination in healthcare settings. We start with the Rehabilitation Act, specifically Section 504 of the Rehabilitation Act that was passed in 1973. And I think you all are probably very familiar with the Rehabilitation Act, especially if you have children in education settings that need additional supports, whether it's a 504 plan or an IEP, that we often think about the Rehabilitation Act in the context of education. But it's important to know that it also applies to healthcare settings and prohibits discrimination in any program that receives federal funds, such as grants or Medicaid or Medicare. And the Rehabilitation Act requires the provider to provide accommodations to allow equal participation or access to services. And it really set the stage for what we're going to be talking about tonight with the Americans with Disabilities Act. And so, as a really brief overview of the Americans with Disabilities Act, was passed in 1990, and like the Rehabilitation Act, the ADA, or Americans with Disabilities Act, focuses on discrimination and mandates equal access for people with disabilities in all areas of public life, not just those areas that receive federal funding. And so the Americans with Disabilities Act took what was established with the Rehabilitation Act a step further. And the Americans with Disabilities Act covers 5 areas or titles. And we're going to go into a lot more detail about this law, but we're going to focus on titles 2 and 3. And state healthcare agencies run by state and local governments are covered under Title II of the ADA, and healthcare organizations run by private businesses or nonprofits are covered under Title III of the ADA. And so for our purposes tonight in our conversation, we're going to be focusing on Titles 2 and 3 because they are the ones that primarily cover healthcare settings. You'll see at the bottom of this slide the ADA National Network with a QR code, and I throughout this presentation on a couple of the slides, I will bring to your attention some specifically relevant resources as we go along, so that if you choose to use the QR code and provide and link directly to those resources as we go, you have the ability to do so. So if you want to use that code with your phone camera and have the link to that resource, then you can do so. Like Christy mentioned, we will also make sure that you have a document that has links to all of these resources that you will receive after the training. So if you can't access this or you don't want to do so right now, not to worry, you will get all of this information. And we will also, with that resource, provide links to the Spanish version of as many of the resources as we possibly can. So that will also be available in the document that you will receive next week after the presentation. And so the third law that I just wanted to overview really briefly is the Affordable Care Act that was passed in 2010. And like the Rehabilitation Act and the Americans with Disabilities Act, the Affordable Care Act prohibits discrimination on the basis of disability. Again, specifically for a health program or activity that receives federal funding. The Affordable Care Act included multiple other provisions that are definitely beneficial to people with disabilities, including Medicaid expansion, which we're finally in the middle of here in North Carolina, and ending discrimination in insurance coverage for those with pre-existing conditions. But really important to our discussion to get today, the Affordable Care Act charged the U.S. Access Board with developing minimum technical criteria for accessible medical diagnostic equipment. And so these standards did not exist before the passage of the Affordable Care Act for things like exam tables or scales or radiology equipment. This picture on the slide you can see is showing that the person has the getting on the exam table that's lowered, and then when the doctor or physician comes in, he can or she can raise the exam table and reach the patient for an exam more easily. And so it provides height adjustment that provides access for one person in one sense and access for the physician in another. And so we're going to talk in more detail about these standards because they are very important to providing equal access to people with disabilities in healthcare settings. And so, again, even though our focus today is the Americans with Disabilities Act, I wanted to at least provide a really quick overview of those, of all 3 laws, because they all focus on not only equal access for people with disabilities in healthcare settings, but also emphasizing that healthcare entities cannot discriminate or deny care because of a disability. And these are really the two main points that I want you to kind of walk away with today, is understanding these rights that exist under the ADA, as well as the two other federal laws. And so, with that, we're going to jump into more detail on the Americans with Disabilities Act and healthcare. And so, first, it makes sense to talk about who is protected by the ADA. And under the ADA, a person with a disability is someone who has a physical or mental impairment that substantially limits one or more major life activities. And these activities are very wide ranging and can include actions such as sleeping or eating, speaking, breathing, can cover any kind of movements related, walking or standing or balancing, cognitive functions such as thinking or remembering, concentrating, sensory functions like seeing or hearing, tasks like working or reading or learning or communicating, and even the operation of major bodily functions, things like circulation and reproduction, and effects on different on individual organs. And so this all to say that the ADA has a very, very broad definition of disabilities and covers many disabilities that we may not think about, or disabilities that are invisible, that you wouldn't know that somebody has unless that was disclosed. And so it's important to think about this because of the really broad, far reaching definition of disability that is covered, or that is mandated within the Americans with Disabilities Act. And it's also important to know that the ADA protects those who have had a disability in the past, or have had a history or record of um, a disability or impairment. An example of that would be a cancer that is in remission. And it also covers those who may be perceived as having a disability, such as somebody who has, scars from a burn, or um, something else that may be visible, may have long lasting visible indications, but that person may not necessarily regard themselves as having a disability or identify as having a disability. And it also covers those who are close to someone with a disability or associated with a person with a disability. And we'll talk a little bit more about about this as it relates to healthcare. But a child or a parent or a spouse of someone with a disability can also be protected by the Americans with Disabilities Act. And so, as I mentioned before, healthcare facilities fall under Titles 2 and 3 of the ADA. And Title 2 of the ADA applies to those state and local government or public entities. And Title 3 applies to public accommodations. And so, if you look at the list here of examples of healthcare providers, more typical healthcare providers, we think of things like, hospitals, or nursing homes, things like that, health clinics that you would expect, oh yeah, of course they're covered by the Americans with Disabilities Act. But even situations, offices with private physicians, dental offices, mental health services, physical therapy clinics, or providers, occupational therapists, speech therapists, managed care organizations, just a real wide variety of health clinics, professional offices that may exist within somebody's private residence. These are all covered under either Title II or Title III of the Americans with Disabilities Act. And so share this list with you to help emphasize that all healthcare providers are covered under the ADA. And so, when you go and you ask for something or you make a statement related to accessibility, or you ask some of these questions and you get, oh well, we're not, you know, we're not covered under the ADA, or this doesn't apply to us. That's not going to be the case when it comes to healthcare providers. Let's see. There we go. And so we then dive into what does the Americans with Disabilities Act require. Um, the ADA states that services must be delivered so that all people have an equal opportunity to the full benefit of goods, programs, services, and activities in the most integrated setting appropriate. So, in this context of healthcare, this includes reasonable accommodations or modifications, which is the right to have policies, practices, and procedures modified for you. The right to communication that is effective. You should be able to get into and move around facilities, and you should have access to accessible medical equipment. Equal access to goods and services can be met by providing one or all of these, depending on what is needed by an individual. And so we're going to go in more depth with each one of these four areas that fall under the ADA's requirements for having equal access to goods and services, so that you can understand not only what should be provided under the Americans with Disabilities Act, but what you can ask for in a healthcare setting. And so the ADA, as I stated, requires reasonable modifications. And a reasonable modification is a change in policy, practice, or procedure that is done to offer equal access and equal opportunity for a person with a disability. So I want you to think about this in the same way that you would think or ask for a reasonable accommodation for a student with a disability in an educational setting. The accommodation helps to address a barrier that they're experiencing, and it's very individual in nature, right? You ask for that accommodation that is very specific to that person's disability and their needs and the situation that you're in. And it's very much the same way with reasonable modifications in healthcare settings under the Americans with Disabilities Act. Um, the modification to a policy or practice or procedure is that accommodation. It's the accommodation that is required under the ADA if that is needed to provide equal access. But there are also limits to these modifications. And that's where our term reasonable comes in. We hear that word reasonable a lot. It can be very subjective and is often difficult to really understand what that means. According to the definitions within the law, it says that it cannot fundamentally alter or cause undue burden. And so what does that mean, right? Those are words that I feel like are thrown around a lot, but we really need to understand what what that means and where the limitations are so we can understand what we can and can't ask for in healthcare settings. And so, a fundamental alteration is a change so significant to a policy, practice, or procedure that it would change the nature of what is altered, what is offered. So I'll say that again. A fundamental alteration is a change that is so significant to a policy, practice, or procedure that it would change the nature of what is offered. So, for example, it would be a fundamental alteration for a doctor specializing in, foot issues per se, to treat somebody with a heart condition, right? You loved this doctor, they really provided accessible and environment, but what you're asking them to treat you for is outside the scope of their training, right? That would fundamentally alter the services that they provide. And so that would not be a reasonable modification. Um, and so if a provider can demonstrate that making a reasonable modification would be overly expensive or cause um, undue financial burden or completely change the care or service provided, then they would not be required to comply with the ADA requirements. And there are a number of factors to consider before a facility can claim undue burden or fundamental alteration of service. Things like the cost in relation to the size of the organization or business. So, all of these, there are a lot of factors that have to be considered. It is typically a very high bar um, to demonstrate that a reasonable accommodation or a reasonable modification would fundamentally alter or cause undue burden. It's hard to prove that. And so, um, but it's important for you to realize that there those limitations exist, because if you ask for something and you are faced with somebody who says, well, we just can't, we can't afford to do this, what you're asking us to do, then you have to understand really where that line is. And unfortunately, it really is a case by case scenario based on um, the relationship of the cost um, to that size of the um, organization or business that you're working with. But recognizing again that it is a high bar, and so I want to provide examples of reasonable modifications that are often seen in healthcare settings to give you um, to help emphasize that even though that most of the time these modifications, these accommodations that can make a huge difference in someone's ability to access healthcare setting, access the services that are there, really are no cost or have very little cost involved. And so, in most cases, um, reasonable modifications and accommodations are never going to meet that point at which they fundamentally alter or change or cause undue burden. So that's something for you to keep in mind, but the focus of it really should be, as we're talking about today, are those modifications in most cases um, can be are very reasonable to ask for. And some examples of ones that I uh, have worked with people who have used and I have seen, used a lot are related to appointment times. And maybe it's extra time for your appointment because time is needed to adjust to a space or meet staff or have time to for mobility issues or to transfer, or whatever the situation may be for you or your child or someone that you're working with, that is can be addressed often within the context of just the appointment itself and the time that's given, or maybe it's requesting an appointment early in the day or late in the day, whatever works best for that individual. And so thinking about, what are that may not be the typical policy or of that physician to allow an extra 15 minutes, but that would be a very reasonable thing for you to ask, if that really does provide the extra access that's needed. If you have a service animal, making sure that there is that you're allowed to have that service animal anywhere the public is allowed to go, and this includes a doctor's office or a patient hospital room. So again, their practice may not be to allow that animal in a hospital room, but it's a very reasonable modification of their practice to request that that service animal be allowed there, um, in a particular space, again, as long as it does not cause a direct threat or fundamentally alter a service, such as you would not necessarily, because of sterilization, wouldn't necessarily be allowed to take a service animal into an operating room, but it would definitely could be allowed in a hospital room, right, where there you don't have the concerns related to a sterile environment. So again, that's a very reasonable request for somebody who uses a service animal. Um, oh, excuse me, sorry about that. Um, Another example would be assistance filling out paperwork or reading over paperwork, helping somebody understand what is being filled out or signed or the consent form. So, extra assistance with forms or paperwork that's being required. And then finally, one of the other things that was really quite difficult during COVID. It has, I think, since not been quite as much of a problem for families and caregivers, but allowing that. Allowing you as a family member or companion or caregiver to accompany somebody with a disability into a more restricted area. This can still be the case for, when somebody is going for an x-ray or other tests, um, allowing that companion into an area that would not typically, um, you would not typically have somebody go back with you. But in the case of somebody with a disability who needs extra support, whether that's physically or to communicate or to understand what is happening in that scenario, having that extra companion is definitely a modification that can be requested. Um, and that most situations they should be able to allow without, again, without any alteration or undue burden. And then also, just I'll mention masks that were wearing a mask that was often a difficulty during COVID. Changing policies related to mask wearing is a reasonable modification, as well as bringing personal equipment or supplies to a hospital or healthcare setting that work better for you than maybe the equipment or supplies that they would typically provide. And so, moving on to our second area, which is effective communication. And this covers individuals that may have hearing or vision or speech or other communication disabilities that affect communication. The ADA requires that communication with and for people with disabilities is as effective as communication with others, with anybody else. And so, in a healthcare setting, they're required to provide auxiliary aids and services when needed to communicate. So, for an individual that may have vision loss, um, things like a information in alternative formats, large print or braille or electronic information. They may need a qualified reader, someone who is able to read information effectively and accurately and impartially. For somebody who is deaf or has hearing loss, providing American Sign Language interpreter, an oral interpreter, captioning, written materials. So there are lots of different um, accommodations or auxiliary aids that can be provided, especially in healthcare settings. It's really critical that a qualified interpreter, specifically someone who is specializes in medical interpretation, if there is going to be exchange of information with more medical terms or specialized vocabulary, that certification is really critical, that somebody have that level of understanding of the information that is being given and received for those for in healthcare settings. And then for individuals that may have speech disabilities, speech to speech transliterator, a person who is trained to recognize unclear speech and repeat it clearly, um, somebody, a communication board or some other assistive technology may be used in that circumstance. And so just being aware that that if it's something that the individual healthcare provider needs to bring in or provide, that they must provide that service in order to provide effective communication under the Americans with Disabilities Act. Um, it's also important to know that this also applies to companions or family members or caregivers that may be accompanying somebody with a disability to a healthcare setting. So if there is a family member or caregiver um, who is deaf or hard of hearing, that an interpreter may be required to communicate with that um, companion or caregiver, especially if they are the guardian of a minor patient, or needs to be able to, or is a spouse or a partner who needs to be able to make medical decisions for somebody. They need to have full understanding of everything that is going on, even if they are not the patient. And so, affected, that's a situation where the ADA applies to a family member, a caregiver, a companion, in addition to the person with the disability who is receiving care in the healthcare setting. And then it's also important to point out that the healthcare facility should not rely on an accompanying adult or another child that's with the individual to facilitate communication. That it's really critical that the provider bring in whatever communication aid, auxiliary aid, or accommodation is necessary to communicate to provide that impartial um, ability to communicate so that you're not involving the potential emotions or perspective of somebody else who is maybe a little too close to the situation to be qualified to provide that communication. So I wanted to talk a little bit more in detail about factors that determine the type of aid that can be provided or should be provided for effective communication. And this is really important if you or your child or somebody that you're working with requires an accommodation for communication, is that you really need to understand the factors to consider so that you're aware what you can ask for to best meet the needs of you or your child or the person that you're with or are there with. And the key to deciding what aid or service is needed to communicate effectively is to consider the nature and length and complexity and context of the communication, as well as the person's normal method or methods of communication. And so that first number one is really the key in this. Asking what is the method of communication that's typically used by that individual? And then taking into consideration the length of that communication and the complexity and the nature of the setting that you're in. And so all of these four elements have to come together to really decide what is the best type of auxiliary aid and what you can ask for in a healthcare setting. And so, as an example, um, so if you are if you have a very brief, simple face-to-face conversation, such as an inquiry, a visitor's inquiry about a patient's room, and you're going to the hospital and you need to find somebody's room number, and all you need is that actual room number. Then something as simple as exchanging written notes or pointing to items, or using very simple, non-technical form of communication would work in that circumstance. It's a very quick, it's face to face, and it's doesn't involve a lot of complexity. And so, more complicated and interactive communications, such as if you're discussing symptoms or treatment with a medical personnel, or if a physician is providing a diagnosis or treatment options to patients or family members, it's going to be necessary potentially to have um, a qualified sign language interpreter, or another kind of interpretation that would provide much more effective communication, where that is a much more complex situation and you need for that person to have full understanding and get all of the information that they need effectively. And so when choosing an aid or service, Title II entities, which again are those um, state and local government entities, healthcare, are required to give primary consideration or choice to of aid or service to the person who has a communication disability. So again, Title II, state and local, those healthcare entities that are run by state and local governments have to give preference to what that person requests for a communication accommodation and honor that choice. For Title III healthcare entities, which are public accommodations, the private nonprofit healthcare entities are encouraged to consult with a person with disability to discuss what aid is appropriate. So you would hope that they would honor that person's individual request, method of communication, but there's a little bit more leeway in what they're required to do under Title III as opposed to Title II. And that gets a little bit, I know that that gets a little bit confusing. And if you all have questions about that, I can do my best to answer those more specifically, but I want to keep us moving so that we don't run out of time. And so just knowing that there may be different factors involved in how a communication aid is provided and what can be asked for, but to remember that communicating what works best for that individual is the first place to start. And so the ADA ensures access for people with disabilities with relation to accessible facilities. And this is the thing that we normally think about when we talk about the Americans with Disabilities Act. New facilities are required to comply with 2010 ADA standards that were developed by the Access Board and apply to public places, commercial facilities, government entities. And these standards set minimum requirements for healthcare facilities to be accessible. And they really represent civil rights by addressing the physical barriers as obstacles to equal access and opportunity. And so new facilities have to comply to those standards if they were built after the passage of the ADA. The existing facilities are required to remove barriers when readily achievable. And this, again, we're dealing with a term that is often subjective. Readily achievable means that it can be carried out without much difficulty or expense. It's important to keep in mind that many of the barriers that we encounter in healthcare facilities can often be achieved by making simple changes to the physical environment. And this, I'm going to take a couple minutes of the next couple of slides to highlight some of the priority areas that we often find in healthcare spaces, just to give you an idea of some of the things to be looking for, some of the areas where barriers are often found and can often be removed pretty easily without significant financial burden or expense. The resource that's at the bottom of this slide is called the ADA Readily Achievable Barrier Removal Checklist for Existing Facilities. That's a mouthful, but this resource is really great because it provides just a very simplified breakdown of those standards and what different areas are supposed to look like under the ADA. Things like parking and restrooms and how big they're supposed to be and why those dimensions are there and why certain ADA requirements exist. And so it really does break that down pretty nicely and is an interesting checklist to look at if you're specifically looking at a certain facility or area or have questions about some of those specific requirements. So this is a real quick picture of what an ideal entrance would look like. You would have parking spaces that are accessible, that have what's called an access aisle, or the aisle with the lines through it to discourage parking, to allow somebody extra space to get in and out of a vehicle. And all accessible spaces have to have an access aisle. One out of every 6 spaces must be van accessible, which means that they have even a larger access aisle to allow space for somebody to get in and out of a van with a lift. That parking area needs to be level and smooth and have a way to get from the parking lot onto a sidewalk, which is usually a curb cut or a curb ramp, to get from the parking lot onto the sidewalk that is not too steep. And then you will see the shaded areas that are from the parking area into the entrance show a 36-inch path of travel, which allows space for most people, most mobility devices to get from point A to point B without having other barriers or obstacles in the way. And so that's the path of travel. The entrance of the building in this picture shows no stairs. Ideally, you would have either no stairs or a ramp to access the front of a building, or a sign that shows you where an accessible entrance is. And so these are just some of just touching on a couple of the things that are critical for that healthcare facility or building to be accessible under the ADA. And if we look now to once you get inside the building, this picture touches on a couple of those things that you would look at inside, such as, again, our 36-inch path of travel, doorways that are 32 inches, space for somebody with a mobility device to pass somebody or turn around. And then objects that don't stick out into your hallway or path that you're traveling too much, so that somebody with a disability that affects their vision can detect that object without that being a safety hazard for them. I find in healthcare settings that buildings may be built with these ideas in mind, but once people are there, they're putting trash cans or medical carts or chairs, can often create those unintentional barriers that make moving around a medical facility or healthcare facility more difficult. And as you all, I know, have all been in exam rooms that are crammed full of all kinds of extra chairs and equipment and blood pressure monitors here and there and everywhere. And so all of these things that um, are temporary objects can also create barriers in interior spaces. Uh, So, just again, something to be aware of there. And then finally, talking just about restrooms. This is often the place that um, see some of the most barriers for individuals, specifically related to the size of an accessible stall, or having an accessible stall that's available that's at least 60 inches wide to allow somebody space to be able to transfer, and having those grab bars and a toilet height that's accessible. But one of the most common things is actually just getting in the door of the restroom, and those doors are incredibly heavy oftentimes. But the ADA mandates that the door take less than 5 pounds of force to open. And I can tell you, most of the doors that I try and open in and out of restrooms are far more um, than 5 pounds of force to open those doors. And so, again, all of these requirements that are set forth in the ADA are really important to be able to provide access in these different areas of healthcare settings. And so we didn't really even begin to scratch the surface on some of these. And so that's where hopefully the resources um, that I can provide and in a little bit deeper diving on your side can um, look more closely if some in some of these areas if that's of interest to you or important to you. And then the fourth area that I want to touch on related to what the ADA requires is accessible diagnostic equipment. Um, and this one is a little bit trickier because the accessible equipment is required under the Americans with Disabilities Act and Section 504 of the Rehabilitation Act to provide equal access. For those with mobility disabilities, it's critical to have accessible equipment, accessible exam tables or diagnostic equipment in order to receive equal services. But the dilemma is that there there have been a lack of enforceable standards, which has allowed continued widespread discrimination in healthcare for people with mobility disabilities. So while the ADA requires equal access, and if you need accessible equipment to receive equal services, um, but there's no enforceable standards. And so those standards that were developed by the US Access Board um, that were mandated by the Affordable Care Act. So the Affordable Care Act mandated that the standards be developed, but the standards are not yet enforceable until they are adopted by the Department of Justice. And so we've got these great standards, but they're not enforceable. And so that creates a dilemma for those of us, myself included, that need this equipment in order to receive equal services. And so that's want to be very frank about kind of where we are in terms of the enforceability of these standards and what we can um, what can be mandated. But I want you to be aware of some of this equipment because when it's provided, it does allow for um, that equal access that is mandated by the Americans with Disabilities Act. And so while they're not yet enforceable, they are best practice. And that's why I want you to be aware of this, because it's something that you can request. It's something that you can educate providers about and share with them about in order to hopefully get them on board with this. And so we're going to talk really briefly about height adjustable exam tables and scales, because those are some of the most common. This resource at the bottom, access to medical care for individuals with mobility disabilities, goes into a lot more depth about some of this accessible diagnostic equipment. So that would be a good resource to look at to get more information. So thinking about accessible exam tables and chairs, this picture shows you kind of the difference between an exam table that is height adjustable, that allows for an accessible transfer height, and one that we typically see in most all doctors' offices, which is usually about 32 inches tall. And this is obviously not me, but if I were sitting in my wheelchair next to one of these tables, it would look very, very similar. There was no way that I can get from my wheelchair onto that typical fixed height table. And so, if I'm going into a physician's office and need to have an exam, and all they have is that high table, then there's no way for me to get an exam like they would give to anybody else who came in the room. And so I'm not receiving equal access. And so the standards that I talked about give much more specific information about the height range and the surface, and some of the having things like rails or other supports to help with the transfer, or provide some of those guidelines for equipment manufacturers to be able to provide accessible exam tables and chairs, but also for physicians to know what to look for and what it constitutes a exam table that is accessible. And so the other thing that is critical to think about is accessible weight scales. So, weight is really critical for diagnostic purposes, for dosage when prescribing medication. And so, the inability to um, provide or get a proper weight for somebody is unequal care. And so that's why accessible scales are included as in these standards, because making sure that somebody who uses a mobility device and is not able to access a scale, stand up and access a traditional standing scale, can still get proper weight, so that all of these other elements of their care can be managed appropriately and equally, just like would for anybody else going into the doctor's office and getting their accurate weight. And so, what many physicians don't really realize is how easily and relatively inexpensively they can provide proper weight with an accessible scale. Um, they're very easy to come by. You can buy them on Amazon, and you know they can be, in the scheme of things, relatively inexpensive. $1,000, that for a physician practice is not necessarily a huge expense, but it makes a huge difference in the ability of that individual to receive equal medical services. And so I'll share with you, I told you that this is this idea of the standards for accessible medical equipment is kind of in flux. It's not enforceable right now, but there is a rule that was just proposed last month by the US Department of Health and Human Services that establishes enforceable standards for accessible medical equipment. So this is a really significant and concrete steps toward addressing um, health disparities and discrimination experienced by people with disabilities, specifically mobility disabilities, in healthcare settings. And it requires that healthcare providers that receive federal funds have to follow these accessibility standards for medical diagnostic equipment or accessible medical equipment that was developed by the US Access Board. And so, specifically, hospitals or clinics or doctors' offices will be required to have a designated number of accessible exam tables and accessible scales as determined by their size. Um, but even smaller doctor's offices will be required to at least have one accessible exam table and one accessible scale. And so I have included at the bottom of this a fact sheet about this proposed rule, because we're still in the comment period for this rule. And so the comment period lasts until November 13th. And they're looking for, people who want to look specifically at what this rule proposes and either, make some comment or provide other feedback related to it, that option still exists. And so this is encouraging because this means that it will eventually happen. We don't have a time frame quite yet, but hoping within, say the next year, that these standards for accessible medical equipment will soon be enforceable. So in the absence of these enforceable standards, providers again still have the obligation to provide access to goods and services, right? So it's kind of that a little bit of a nondescript area where we find ourselves between what the ADA says related to accessible medical equipment and what's enforceable, and this time period that we're in right now, waiting for these standards to be enforceable. So I hope that didn't cause too much confusion. We'll definitely address that further if we need to. And so I wanted to, before we go to any questions that are out there, want to give some background and some information on what I have found helps in advocating for access in healthcare settings. And I picked this picture because for me, in many cases, it is very much seemed like kind of a rough road and an uphill battle with this. But I feel like in many cases, having dealt with this over the course of 40 years or so, um, I'm far more optimistic about kind of where we are and where we're going related to the ADA in healthcare settings, and having physicians and folks really understand what they need to be doing and what they need to be providing. And so there are some, again, some really general tips and things to think about that have worked well for me over the years when advocating for my needs. And it really starts before I even go into a healthcare facility or doctor's office and calling first to ask um, about accessibility or the availability of accessible equipment. I have a list of things that I know I need when I am visiting a healthcare provider, and I'm sure for you that's going to be a very different list. But kind of knowing exactly what you need to ask ahead of time and making that phone call and asking for what you need before that appointment is really critical to getting the access that you do need. So whether that's asking about accessibility ahead of time, if that's something that's going to be critical for you or your child or those that you care for or work with, um, requesting any modifications to appointment times, modifications to other policies or practices that are going to be critical to make that appointment, make that visit go well, any assistance that may be needed. during that visit, making sure that those requests are made before the appointment and ahead of time so that that expectation is there first. And being very specific about that communication, if it's a communication accommodation, being very specific about what your needs are, any forms or materials that may be needed in alternative formats. And I think some of these initial conversations with office staff, with those who make the appointment ahead of time, really give you a lot of insight into what you might encounter when you get there. And there have been situations where I have called and asked, excuse me, about accessibility. I've asked about some of the availability of accessible equipment. And based on the reaction of even the front office, the person who's making the appointment or that front office staff, in terms of either not having any idea what I'm talking about um, or creating a sense that this is really not where I want to be going for my healthcare. I've decided, well, you know what, this is not the office, this is not the physician that I'm not ready to tackle the advocacy that would be needed in this situation, and so I potentially will move on to another provider if that's an option. Sometimes that's not an option, depending on where you are or what's available. Um, this resource at the bottom of this slide is it's a guide from the Centers for Medicare and Medicaid. I like it because it's directed at patients, at people with disabilities, and it starts out with what your rights are, and so it lays out very clearly what your rights are, what you can ask for in an appointment in a healthcare setting. But the other strength of this resource is that it's available in 8 languages and is also available in alternate formats. And it really is one of the few resources that I have found that that has that much um, availability related to language and being available in alternate formats. And so that's why I share that with you. And then wanted to share process that if you go into a healthcare facility, you go and you encounter some barriers, whether those are physical barriers, communication, not making requested modifications. There are lots of different circumstances, but wanted to just share, just again, this is what um, I have found have worked in several situations. You will see it's probably very similar to you advocating in other settings, in education settings, and in other places. It's a similar kind of approach and mindset. When I was pregnant with my first child, had recommended to go see a obstetrician that had some background with some of my medical concerns, and so went in to see her and had a conversation, and we started talking and realized that there was no way for her to get my weight when I came in for prenatal care. And that, as you all know, is really critical. The weight, your weight is going to show the health of the baby in addition to your own health. And so that was really critical. And so I had conversations with her, and I asked her what if there was any other way, any other place that had an accessible scale. Um, and so we couldn't come up with a solution there, and so I went back. This is before accessible scales were very prevalent. Went back home, did some research. I called some people, asked some questions, and went back to her with a couple of scales that were being manufactured that were accessible, and shared that information with her and those resources, and ended up having many more conversations with the office manager as opposed to the provider herself, just because of her time. And within, you know, it was probably a month that I went back, and she had purchased an accessible scale for her physician's office. And that, that to me was the first time that I had really gone in and advocated for something and seen results that quickly. And that doesn't always happen. And there are many more times that I've had um, hit brick walls, or had people say, "Oh, I'll look into it," or you know, we'll look at the budget, or whatever um, the situation is, or the often excuses for not wanting to deal with it. But it's really where you decide how hard you're willing to fight for some of the things that you need in a healthcare setting. But again, bringing it to the attention of the provider during the appointment, first thing, having the attitude of um, sharing those solutions, sharing those information and resources, having that readily available so that you can go to them and say, okay, this is what I need. This is how to get it. This is what we can do. Here's that information. Like we talked about in the beginning, with the provider's perceptions, they are not going to be the ones that are going to know what to do next, or know where to find the information, know where to find the resources. I think in most cases, I think that comes back to us to provide that. Excuse me. And then, when if you encounter that resistance, seeking support, whether that's support within an organization like ECAC that has, um, family support people that have been there and done that, and have that experience, or an organization that I've listed here called Disability Rights North Carolina, that it's designed to provide support for individuals who are experiencing discrimination related to the Americans with Disabilities Act. And so you go then to the expert that can provide that information. And then finally, um, if it comes down to it, there's always the option to file a complaint with the Department of Justice. And this QR code um, links to a resource sheet on how to file a complaint with the Department of Justice. The ADA is, there are not people that go around and monitor the ADA. The only enforcement of the ADA comes when a complaint is filed with the Department of Justice. And so, if that becomes the next step, it's really an important step, because that's how changes are made in some cases, and oftentimes it can be done through what they call the ADA mediation program, which allows for that it doesn't involve the courts. And so it allows for meetings between you and the organization and a mediator, and is designed to reach a mutual agreement for access, to get things changed, get you what you need in terms of access and medical settings. And the other thing that I will say is that there is a lot of effort being made right now to focusing on um, ADA enforcement within healthcare settings. It's called the Barrier Free Healthcare Initiative. And so they are really looking specifically at those complaints that come in related to medical services and facilities, such as effective communication or physical access in healthcare settings. And so, all of that to say, in many cases, those complaints definitely are heard. Um, and I want to make sure we have time for questions. There was one, I think that I've answered hopefully a couple of the questions that have come up or that came up that you all asked ahead of time. There was one in particular that I wanted to go back to because it somewhat dealt with this slide a little bit. That there were a couple of questions that you all had asked related to advocating for equal care when faced with a doctor's assumption or preconceived idea about a disability and overlooking some of those symptoms. And so I wanted to go back and address that with this slide because, in many ways, you're following some of the same strategies, but there are a couple of things that may be a little bit different. I think that when you encounter a situation where the barrier is not as straightforward as a communication barrier, a physical barrier, or, you know, something where they're not willing to make a modification, but you're dealing with a bias or an assumption by a physician that you feel like is affecting the equality of care that you or your child or your person that you're caring for is receiving. I think the first step is recognizing that um, that doctors may have bias or assumptions, right? I mean, we all have some level of bias, and I think that is definitely the case in healthcare settings. And that recognizing that bias is often the first step. It doesn't make them a bad a bad doctor. It just may mean that you have to continue to advocate in that situation. And in most of and the this often occurs where a doctor will look at a person's disability and not necessarily consider all of the symptoms is called diagnostic overshadowing, when a known underlying condition leads to assumptions about a patient that prevent physicians from making a new diagnosis that may mimic those symptoms. So, recognizing first that the doctor may have bias, recognizing that there may be a tendency for diagnostic overshadowing or kind of overlooking those symptoms. And then, if you suspect that and it's impacting the care you're receiving or leading to some kind of diagnostic overshadowing, then just really being empowered to speak up. I have actually done this myself a couple of times, and what I've said to the doctor, and this is what I, have actually said to them, is I'm not sure that these symptoms are related to my disability, and I would like to explore other potential causes first. And so, really pushing to have that doctor explore other tests or other options to make sure that there is not that tendency to rely on, overlook symptoms that occur because of a disability. And so, and then also just, if a second opinion is needed, a second opinion is needed. So just keeping that in mind. So I wanted to at least address that question before we got to some of the others. But I'll let Christy look at the questions that we have in the Q&A.
Thank you so much, Lauren, for all that wonderful information and some great recommendations and strategies. Thank you so much for sharing all of that. Fantastic. So we do have a couple of questions. The first one, let's see, we got just a few minutes, so we may only have time for this one. I've answered a couple where I just typed an answer because they were regarding IEPs. But first question is, what if the physician's office is located inside of a building that is not owned by them? For example, physician rents a second floor office in a church building. The elevator's in the lobby, not in the physician's rented office space. Elevator is often out of service, making ability to enter inaccessible, but the church owner will not fix or open the elevator. Is the physician still in compliance?
So that's a great question. You
Thanks,
raise a
Allie.
couple of, yeah, a couple of tricky issues there. A rented space would still be required um, to provide accessibility. So even if the space is rented, they're still required to provide access. The fact that it's a church provides a little element of complexity because the ADA does have provisions for religious institutions related to accessibility. The key question in this would be whether the physician is accepting federal funds. So if they are a physician that takes Medicare or Medicaid, they would not necessarily be required under ADA because it's in a religious, because of the religious clause, but they are required to provide equal access to services under 504 of the Rehabilitation Act. And so if they are receiving federal funds, even if they're in a church building, they have to comply with 504 of the Rehabilitation Act and then provide accessible service. So if the elevator is out of service, making it inaccessible, then they need to be able to provide that service in an accessible location if that location can't be made accessible. So I hope that answers it a little bit. And I can, if there this would be one that if it's something that's a continual problem, expertise from like Disability Rights North Carolina, somebody like that would be able to provide some additional guidance on kind of what steps to take next.
Yeah, fantastic. Thank you. There was another question, and I'll just give you the gist, and I don't know if you'll be able to speak to it. But it was regarding a theater class performance. So I'm assuming that this is probably a private organization or entity. If it's not, you can let us know in the chat. But I guess the daughter basically did not get a preferred role and spent time sitting there while other kids had roles, and was offered a different role. I guess it looks like it was some inequity in the roles that were offered. Public school. Oh, it's public school. A public school theater class. Okay, so this has to do with the school system. Okay, well, that would probably be a school related issue. And I don't know if you have anything you want to say about that, but
Yeah, I would definitely defer to those that are experts like
yeah.
like your
So
like folks at ECAC
yeah.
specifically related to
So
education.
specifically, this is probably
Yeah.
something, yeah. So because it's in the public school, I would definitely reach out. And you can utilize our web inquiry link and reach out to ECAC, and you can have a parent educator work with you. And really specific situations like this, discussing them publicly, just for privacy reasons. We don't typically like to do that. But in my mind, I was picturing like a private theater program. My daughter does theater in a private program. So that's where my brain went. So yeah, anything to do with the public schools, just reach out to us individually, and we'd be happy. Let's see a comment. Lauren, thank you for presenting this evening. The information was definitely,
And I will say just,
yeah.
to that, even if it's a private facility, they're still covered under Title III as a public accommodation. So we often hear the word private and think, oh, ADA doesn't
Right.
apply. ADA applies as long as the
Mm.
public is allowed in there. So if it's a theater program or dance program or whatever the case is, it's still a public accommodation, even if it's privately owned.
Right.
And so that's just that distinction is really important because we don't want to just let them off the hook just because we say they're private.
That's true. Very good point. Very good point. I will check the Q&A box one more time, see if there's anything new. And I don't think there is. So people are giving you thanks in the chat, and I want to give you some thanks as well. And thank you to both of our interpreters for working so hard. I know it's really hard and exhausting to do that work. So thank you so much for helping us make this accessible. And with that, I would just like to say one more time, thank you to Lauren for presenting. And I will send a follow-up email. It will be on Monday. So we have time to get this recording posted and to get the PDF of the slides and to get some additional resources and information from Lauren. And we will get that email out to everybody who registered. So thank you so much for joining us tonight. And we hope you can join us again for another webinar soon. Have a good night, everyone.
Thank you all.